warmly welcome you to the 5th webinar in Arthritis and Osteoporosis Victoria's 2015 Musculoskeletal Health webinar series. Tonight's webinar is on the subject of common sleep problems and strategies to assist people to sleep better. Before introducing our presenter for this evening, I just have a couple of housekeeping issues to run through. Firstly, if you have any technical difficulties during the webinar, please refer to the message box on your screen. You can type a message at any time for the organiser at Redback Conferencing. If you are listening via the phone, you will notice a small time delay between the audio and the screen. This is normal, so don't be concerned. Also, whilst our presenter will answer questions after the completion of his presentation, you can actually type questions for him at any time. Can I suggest that you don't leave your questions to the last minute, as we will aim to finish strictly at 8 p.m. Eastern Standard Time. Our presenter has also agreed to answer any questions offline, and we can provide those questions to you post the webinar screening this evening if that's necessary. I would also be very grateful if all participants could take a moment at the end of the webinar to complete the exit survey. It'll only take you approximately 30 seconds to complete, and that information is very valuable to us. Also, we will be sending out information soon about the webinars in the second half of the year that we'll be screening as part of our Musculoskeletal Health webinar series, so please keep an eye out for this information coming your way soon. Our presenter for tonight is Dr Christopher Worsnop. Christopher is a respiratory and sleep physician at the Austin Hospital and adjunct associate professor at RMIT University in Melbourne. He also works at the Northern Health Hospital. Sleep medicine is a significant part of his clinical work, and he sees patients with a broad range of sleep problems. Without further ado, I'll hand proceedings over to Christopher. Thanks very much, Christopher.
Thanks very much, Genevieve, and good evening, everyone. Sleep disorders can be broadly categorized into insomnia. So this is when people complain about not being able to get to sleep or can't staying asleep after they have fallen asleep. So basically, it's a problem of perception of patients not being able to sleep when they want to. The second broad group are people who have hypersomnolence, so that they are falling asleep when they don't mean to. And there are a number of causes for that. I'll be specifically addressing insomnia, as that is very common in our community. And then later in the webinar, I'll talk about two very common causes of hypersomnolence, which are obstructive sleep apnea and periodic leg movements. So insomnia is a complaint that patients make with dissatisfaction with their sleep quality and or duration. It's broken down into two broad groups. One is that they have difficulty initiating sleep, so they can't get to sleep when they first want to, or they have difficulty maintaining sleep, so that they can fall asleep easily but wake up too early and then can't get back to sleep. Of course, patients can have both difficulty initiating as well as maintaining sleep. Circadian rhythm disturbances are also common in our community. So our propensity to want to sleep is controlled by a body clock in the base of the brain associated with the pineal gland and also the release of melatonin hormone. It's also linked to body temperature. So our body clock will typically tell us to go to sleep in the late evening, say 10 or 11 o'clock, and then to wake up again in the morning, say around 6, 7, 8 o'clock. But if we're trying to sleep at different hours from when our body clock wants us to sleep, then this can also lead to sleep disturbances and people will present with insomnia. Insomnia can be a primary problem, so that it comes out of the blue and that's mainly what the patient has, or it can also be secondary to other problems. Insomnia is commonly associated with depression and anxiety. So most people with depression will have issues with their sleep, both being tired during the day, but also having difficulty with sleep at night. And people with anxiety can often have difficulty falling asleep because they worry about various things that are associated with their anxiety. Physical issues are also very important and need to be addressed. So in this context, pain is particularly important. So for example, people with arthritis who have pain during the night, the pain will disrupt their sleep. But other physical things can do it as well, such as breathlessness, for example, with heart disease or chronic lung diseases like COPD. Sometimes gastroesophageal reflux can do it, and less commonly hyperthyroidism can keep people awake as well. When there are these other physical conditions, it is important that the underlying physical condition is treated, because if someone has persistent pain, treating the insomnia itself is not going to relieve their sleep problems. The pain also needs to be treated. However, it's not simply enough just to treat the physical problem, because once insomnia has developed, the insomnia itself also needs to be treated. So it's important to treat both things together or in parallel, both the underlying physical or psychological problem as well as the insomnia itself. Drugs are also an issue that can cause insomnia, and of course the common drug that gets used in our community is caffeine. So taking a very history about caffeine intake is important. Obviously it's in coffee, but also tea, chocolate preparations, as well as a lot of energy drinks these days will have caffeine in them. And also people involved in sport, so taking various sports gels and sports drinks, can be consuming quite a lot of caffeine without realizing it. And some over-the-counter weight loss preparations also have caffeine in them as well. And the caffeine can persist for quite some time. So people with insomnia really need to try and avoid caffeine as much as possible. And in fact, people who are particularly sleepy tend to use caffeine to try and keep themselves awake. Other drugs can sometimes do it as well, particularly a lot of the psychiatric drugs and the various antidepressants are well known for causing insomnia. So any psychoactive drugs need to be reviewed and to see if their use is really needed. Environmental factors can also be important, but often patients have worked out to deal with these themselves. So for example, it's too noisy, it's too light, it's too dark, it's too hot, it's too cold, all these sorts of things. But sometimes patients tend to neglect having a comfortable and quiet sleep environment, so these issues ought to be addressed as well. Occasionally, some people have unrealistic expectations about how much they need to sleep. So that a patient will come in saying that they can't really sleep as much as they want, they're waking up too early. And this tends to occur in people who are bored, so newly retired people or unemployed people. They have nothing much to do all day. So when you take a careful sleep history and find out that they're going to bed at 9 o'clock at night and then getting up at 9 o'clock in the morning, they're not going to be able to sleep for 12 hours throughout the night. They're having unrealistic expectations about how much sleep they should be getting, so they need counselling about that. Some people classify insomnia into cognitive and behavioural aspects. So the cognitive ones are things like I've just explained, having unrealistic expectations, also worrying about things. Obviously it's difficult to sleep if someone is worrying about their health, their children, their job, financial concerns, whatever. Of course, a common problem is that people start to worry about their sleep, so that they have difficulty falling asleep because they worry about whether or not they're going to sleep well that night and how they'll be able to cope during the day. So that's important to identify, because dealing with anxiety and worry about sleep is an important part of the management of insomnia. Also, people have misconceptions about sleep, trying to force themselves to go to sleep, worrying that they're having the wrong type of sleep or whatever. And also some people have just poor coping skills with life in general. Behavioural things are things like people being hyper-aroused. So they've spent a lot of time doing work on the internet, things like that, just before they go to bed, so that their brain is not relaxed and ready to sleep. So they need to have some relaxation time before they go to sleep. Spending excessive time in bed, so that they learn that the bed is there for doing activities like reading, watching television, working on the internet, watching webinars or whatever, rather than sleeping. So we need to address those as well. It is important to have irregular sleep times. So people that vary their sleep times across between the weekdays or weekend, or especially people on shift work, can have trouble getting into good sleep habits. And also activities that reduce sleep. So for example, doing some heavy exercise just before going to bed, having a big meal can make it difficult for people to sleep. So all of these different aspects need to be considered when talking to people about their sleep and potential insomnia, because when these issues become identified, then we try to address them in treating the people's insomnia. The Spielman has a very nice model of insomnia, and you can see there that on this graph there's a certain threshold for developing insomnia. So once we go above that threshold, then we do have difficulty with our sleep. And you can see the aqua-coloured bar there is giving an idea about some people will have a tendency to have trouble with sleep because they tend to worry or be anxious or whatever. And some people, this bar is very low, so they never have any trouble sleeping. It doesn't matter what's happening in their lives. They always seem to be able to sleep no matter where they are, strange beds, motels, friends' couches or whatever. Whereas other people have a very high aqua bar, so they're close to the insomnia threshold. So they are very particular about what sort of bed they're sleeping in. They have to have the right pillow. They can't have too many worries or things. And if any little thing happens, they can go above the threshold. So it explains the individual variation in people's propensity to develop insomnia or not. And of course, on top of that innate predisposition that all of us have to either sleep well or not sleep well, there are certain acute things that can happen in our lives that can push us above the threshold. So some sort of life stress, exams coming up, job loss, bereavement, things like that, that can make it difficult for us to sleep because we're worried or stressed about these different things. So that, how we respond to that on top of our natural predisposition can sometimes push people over that threshold into having insomnia. Over time, these acute things diminish and become less of a factor. But some people can be left with persistent insomnia even though the acute life stresses have resolved. So that during the period when the acute stresses are there, people develop behaviours that are maladaptive, that tend to predispose them to maintaining poor sleep habits and having insomnia. So people can end up with chronic insomnia. So this is the tendency to develop these bad habits on top of their innate tendency to have poor sleep. And these can persist even when the acute episode has resolved. So that's why when dealing with insomnia, we need to deal with the acute episodes, so whether it's a psychological issue such as bereavement, worry, stress, or a physical issue such as pain related to arthritis or whatever, as well as dealing with their propensity to sleep and worry about sleep. So drugs that can cause insomnia, as I said before, caffeine is particularly important. Theophylline is a drug that has similar activities to caffeine, although we hardly use that these days. Beta blockers can do it. Antidepressants, as I said, and most of the modern antidepressants can predispose people to insomnia. The one exception would be the melatonin antagonist, agonistin. Amphetamines, so obviously these are illicit in Australia, but they do tend to be used in the community for recreational use, but in some jobs people use them, like truck drivers, to keep themselves awake for long periods. Corticosteroids are well known for causing sleep disturbance, so people going on to prednisolone, dopamine antagonists, and of course nasal decongestants can do it to a degree as well. Another aspect of insomnia is a thing called paradoxical insomnia. This is when people complain about not being able to sleep, either hardly sleeping at all, or some people say that they never seem to sleep. They do go to bed at a reasonable hour and spend a normal time of in bed, like 7 or 8 hours, but they feel as if they just lie awake all night, and then they get up in the morning and say, look, I didn't sleep all night, what's wrong with me? They tend to not have very much in the way of daytime sleepiness, and when we study them in the sleep laboratory, we find out that they are in fact sleeping quite normally, but they have a very poor perception of their sleep. It is very common that people cannot perceive how much they're sleeping or cannot accurately determine how long they're falling asleep. So one aspect of the management of insomnia and these type of sleep issues is to get people to not think about their sleep at all, not to worry about it, just to put themselves in an environment where they are relaxed and think about anything else other than sleep and just let sleep happen. So people with insomnia have trouble passively abandoning wakefulness. And I liken it to going into a butterfly house and trying to catch a butterfly. People that run around trying grabbing the butterflies are not successful in catching a butterfly, but if one stands still with the arm outstretched, the butterfly will come and land on the arm. So sleep is like that. We cannot actively put ourselves to sleep. The best that we can do is to put ourselves in a situation where we're relaxed, both physically and also mentally, and the sleep will come to us. So we need to try to ignore that tendency to worry about sleep, to try to get to sleep. So we want to just be passive and let sleep come to us. And this is the message to try to get across to patients. Mental activity does persist in non-REM sleep, so that sometimes people will remember this activity when they wake up and think that they have been awake thinking about things during the night, when in fact they have been asleep and some mental activity has been occurring which they're remembering next morning. So again, they need to be told, don't worry about that, it's quite normal. If you do happen to remember things that were going on in your subconscious next morning, it doesn't mean you didn't sleep. And as long as you're functioning during the day, not being too tired, then you are getting adequate sleep and sleep of adequate quality during the night. So when taking a sleep history in people who have sleep problems, we need to ask what time people go to bed, and then how long does it take to fall asleep, how long they estimate to fall asleep. And if they're saying it takes a reasonable amount of time, like half an hour or longer, we need to find out what they're doing during that time. Are they reading books, watching television, on the computers or whatever, or are they passively trying to relax and let sleep come to them? Also to find out what time they get up in the morning, and if they wake up during the night, and if so, how often, and to give an estimate for how long. We also should ask if they're having a nap during the day, and also ask about dozing off at other times. People often think about a nap as when they deliberately try to go to sleep, but sometimes people will doze off watching the television or whatever. Now these sort of naps during the day can make it more difficult to fall asleep at night. So one way of dealing with insomnia is that a person either has to accept that they'll have a nap during the day and then sleep less at night, or that to really carefully avoid having any sort of naps, including dozing off in front of the television and so on, so that they can sleep better at night. We do need to remember, though, that when we ask patients these questions, particularly about how long they take to fall asleep and for how long they are sleeping, is that the patients are just giving a bit of an idea so that we can get a feel for their perception of their own sleep. Their actual ability to estimate these things is not very good. And we've done a study specifically looking into this at the Austin and find that people do tend to overestimate how long they take to fall asleep, although some people do the opposite and underestimate it. The point is that people are not very accurate in being able to judge how long they take to fall asleep or how long they sleep. Some people in insomnia clinics will get people to keep a sleep diary, so over a fortnight, so that they'll actually document all these sorts of things every day, so that a pattern can be observed. And then if there's something abnormal or maladaptive about that pattern, then those issues can be addressed with more intense counselling in insomnia clinics. So the management of insomnia is important. Obviously, as I said earlier, it is important to identify an underlying cause, such as physical problems that the patient may have, psychological issues like depression and anxiety, environmental issues, although hopefully the patient has dealt with those him or herself, and of course medications. So as well as dealing with any underlying causes, we also need to manage the insomnia itself, because often people have developed a learned insomnia, and just removing the original cause won't fix the insomnia in itself. So the mainstay of treatment of insomnia is cognitive behaviour therapy. We don't really use drugs to treat insomnia. The main type of drugs, the benzodiazepines, don't work particularly well compared to the cognitive behavioural techniques. And also people become addicted to them very quickly, and tolerance also develops very quickly so that the effect wears off. The other types of drugs like zolpidem can be used in the very short term, but they're not a long-term solution for insomnia, and they can have significant side effects. So really the primary treatment of insomnia are these psychological treatments, and the classical one is cognitive behavior therapy. Psychologists will typically do this with weekly sessions over 5 to 6 weeks, about an hour each. So if you don't have the time to be able to do it yourself or the expertise, it is worthwhile getting the patient to see a psychologist who has experience in dealing with sleep issues. So what they'll try to do is deal with any causes, as I said before, and then to the behavioural aspect of it is to get into good sleep habits. So this means maintaining strict bedtimes, so going to bed at the same time every night and getting up at the same time every morning, including weekends. And by having a regular bedtime, this helps to teach the brain that going to bed means going to sleep, and also to helps keep the circadian rhythm in a regular pattern. There also should be a quiet, relaxing routine before going to bed. So again, it's a way of teaching the brain that once this routine is happening, then the person is conditioned to go to sleep at the end of the routine. And also it's relaxing, which means that the person is not hyper-aroused before they try to go to sleep. They should also avoid doing anything else in bed, such as reading, using computers, television, and those types of things, so that they're conditioning their brain that going to bed means going to sleep. If they're too active in doing other things in bed, like watching TV and so on, then the brain hasn't learned that going to bed means going to sleep. So it's really developing a conditioning response. Relaxing routine, going to bed means going to sleep. And also they should avoid spending long periods of time just lying awake in bed. If they really can't get to sleep, then they need to get out of bed, go away from the bed, do something relaxing for a while until they feel like they're ready to go to sleep, and then go to bed and go to sleep. They really should not be preoccupied with sleep. So if they find that they can't stop thinking about sleep, they should try and distract themselves by thinking about other relaxing things. You know, the classical sort of image of being on a holiday on a tropical island, that type of thing. So that they're thinking about something pleasant, relaxing, but not about sleep. Because thinking about, am I going to sleep, how long have I been awake, that type of thing, is counterproductive and prevents them from going to sleep. In particular, they shouldn't be looking at a clock. So a clock should not be available, because if they do that, then that will prevent them from going to sleep as well. And there are good clinical trials showing that this cognitive behavior therapy is effective in helping with insomnia, including in people with chronic pain. So it's been specifically tested in that type of situation. Bootsin is well known for the stimulus control therapy. So it's very similar to what I just described, but specifically it's related to improving sleep habits. So having set times when sleep is allowed and avoiding any sleep outside of those particular hours. And again, just going to bed for sleep only, not doing other things in bed, and not staying in bed if one can't sleep, getting up and going back to when one feels ready. And certainly avoiding sleep outside of the bedtimes, because that makes it more difficult for people to go to sleep. All of these things, of course, take time and effort and motivation from the patient. So it's not going to happen overnight, but if they are persistent with this and maintain these habits, they will get long-lasting benefit in improving the quality of their sleep. Some people refer to this as sleep hygiene or improving sleep habits. So as well as what we've just described, avoiding heavy exercise just before going to bed, minimizing or eliminating caffeine altogether. Alcohol can make people feel sleepy, but the quality of the sleep is nowhere near as good. So avoiding alcohol before bed, and nicotine also. Avoiding naps during the days, not having large meals just before bed, dealing with worrying issues before going to bed. So if there is a particular problem that the patient can't solve and it is concerning them, there are psychological techniques to try and deal with that so that they can go to bed having displaced that problem or delayed the assessment of it till tomorrow morning. Now, with things like the exercise and the meals and so on, if the person is not having a problem with their sleep, then it's not an issue. this advice is really only for people who do have insomnia and trouble with their sleep. Obviously, the bed needs to be in the room, comfortable, dark, quiet, and so on. It's really important not to be looking at the clock because that really keeps people awake. And as I said, to get out of bed, if they can't go to sleep, do something relaxing away from the bed and then go back to bed when they're ready to sleep. And getting up at the same time each morning is important. And to help keep the circadian rhythm in synchrony, to get some bright outside light on the eyes when first getting up is also important. As I said, we don't really use the benzodiazepines at all anymore for insomnia. Sometimes people might use zolpidem in the short term. It can increase total sleep time by up to an hour in clinical trials. It doesn't seem to affect the sleep architecture very well, but it does have some significant side effects such as hallucinations, parasomnias like sleepwalking and sleep talking, amnesia, and sometimes suicidal tendencies. So we try to avoid it if at all possible. Now, circadian rhythm disturbances are not uncommon. A delayed sleep phase disorder means that the body clock is wanting us to go to sleep much later. So, for example, it might be wanting us to go to sleep at 3 o'clock in the morning and get up at 11 o'clock in the morning. This is particularly common in teenagers and young adults. So that tendency for them to want to go to sleep later and get up later is in fact normal physiology for them. Advanced sleep phase is when the body clock is telling us to go to bed early, say for example at 8 o'clock, to sleep at 8 o'clock and get up at 4 o'clock in the morning. And this tends to occur in elderly people. So grandma going to bed really early and then getting up in the middle of the night wandering around is again a physiological thing that occurs as we get older. By themselves, these are not problems. So for example, for a chef or a musician or something, having a delayed sleep phase disorder is an advantage. But if it does clash with their lifestyle, then people need to try and shift their circadian rhythm to avoid that. And particularly with shift workers, this can be a big problem. Particularly, it's much worse with rotating shifts. And of course, jet lag is just a very acute form of a circadian rhythm disorder. People who are congenitally blind don't develop a circadian rhythm because we're dependent on light getting onto our eyes and suppressing melatonin from the pineal gland. So they tend to have free-running sleep phase disorder, so they don't have a set circadian rhythm, so insomnia is a common problem with them. And sometimes when people develop dementia, they'll develop a very irregular sleep-wake pattern, basically sleeping like babies, so awake for a few hours, asleep for a few hours, and don't have a normal night-day circadian rhythm that the rest of us do. So the way to deal with circadian rhythm disorders is the person either has to accept it or they can introduce these sort of behavioural techniques to entrain their circadian rhythm. So that means going to bed at the same time, getting up at the same time every day, avoiding any naps outside of those times. And the circadian rhythm can be shifted by getting bright light onto the eyes at certain times of the day. So it does need to be outside light, so room light, as you can see from the table there, is not really bright enough. And the timing and intensity is important. So for example, with a person with a delayed circadian rhythm, tending to want to sleep late and get up late, they should be getting up early in the morning and getting daylight onto their eyes for about half an hour, and that will help shift the circadian rhythm earlier. And it doesn't occur straight away. They need to be doing this on a regular basis for several weeks to really get the full effect. The melatonin can also be used. So this is a hormone that is released from the pineal gland, but it can be bought in tablet forms. So compounding pharmacists do produce melatonin in dosages ranging from 2 to 5 milligrams. And this would be taken about half an hour before the person wants to go to sleep to try and get the circadian rhythm in synchrony. CIRCADIAN is a slow-release preparation that is more indicated for insomnia, but it's also available on prescription in Australia as well. One needs to be careful of homeopathic melatonin. It contains very little real melatonin and is not particularly useful. We don't really know what the long-term side effects of melatonin are, so it's really recommended that it should only be used in the short term for people with phase problems, either shift workers or even with jet lag. So that's the insomnia description and management. I'll now shift over to the other kind of sleep disorders that people have, which are hypersomnolence, or sleeping too much, falling asleep when they don't want to, even though they feel like they've slept adequately. By far the commonest cause of that in our community is just not getting enough sleep. So many people in our community are chronically sleep deprived because they're staying up late at night, watching the cricket or Tour de France, on the computer, Facebook, all those types of things, watching webinars, doing work, and then they're getting up early in the morning to get to work, take the kids to orchestra practice, whatever it is, and then at weekends socialising and not just getting enough sleep. So that's always a major issue that we need to address. And even though we might find another cause for their sleepiness, if we don't deal with this issue of not getting enough sleep, their symptoms of being sleepy are still going to persist. There are a number of drugs that can make people sleepy during the day. Benzodiazepines, which are sometimes used as muscle relaxants or anxiolytics, will also make people feel sleepy. Many of the psychiatric drugs, particularly antidepressants, can make people feel sleepy during the day. Beta blockers can do it as well. So we need to be looking at what drugs people are taking if they're complaining about being sleepy and tired. The third group of disorders are conditions which disrupt sleep. So the person is sleeping during the night, but the quality of sleep is poor because it is repeatedly disrupted. And the commonest ones of these are obstructive sleep apnea and periodic leak movements, and I'll talk about those two in more detail. And then there are rare conditions that can make people sleepy during the day, and these are primary sleep disorders, so narcolepsy and idiopathic hypersomnolence. So these are quite rare, and I won't discuss them any further tonight. So here's a picture of Fat Boy Joe. So he was a character in Pickwick Papers by Charles Dickens, and Dickens gives an absolutely wonderful description of obstructive sleep apnea and the obesity hyperventilation syndrome. So obstructive sleep apnea is now very common, but we just need to clarify the nomenclature. So apnea comes from the Greek, which means not breathing at all. And there are two main types. There's obstructive sleep apnea, which I'll talk about in detail. A much less common one is central sleep apnea. Because obstructive sleep apnea is much more common, when people just say sleep apnea, what they're talking about is obstructive sleep apnea. If they want to say central sleep apnea, they'll say that specifically. And an old term for central sleep apnea is Cheyne-Stokes respiration. Now, hypopnea means that there's been a reduction in breathing, but not a complete cessation. So most people will have a mixture of apneas and hypopneas on a sleep study. So really, they have obstructive sleep apnea, hypopnea. So that's too much of a mouthful, so we just say sleep apnea as an abbreviation of those four words. Sometimes people throw in the word syndrome. What they mean by that is that the person not only has the sleep apnea on a sleep study, but they're clearly symptomatic with it as well. Upper airway resistance syndrome really just means subtle obstructive sleep apnea that is not picked up easily on a standard sleep study. So it's not really a different condition. It just means that more technical recording is needed to be able to identify the subtle apneas and hypopneas. So how does obstructive sleep apnea occur? So the throat is basically a floppy tube. It's a muscular tube. And this is thought to be the case in humans to enable us to produce speech. So other mammals have quite rigid upper airways with bone and cartilage. So this is unique to humans. When we go to sleep, our muscles relax, and this includes the muscles in the upper airway. Because it is a floppy tube, then as we breathe in, we generate a negative pressure from our nose and mouth down into the lungs, and that negative pressure in the upper airway tends to cause the upper airway to collapse. But the upper airway muscles tense up when we breathe in to stop the upper airway muscle from collapsing, the upper airway itself from collapsing. When the muscles relax during sleep, then there is a tendency for the upper airway to collapse a little bit. Now this happens in all of us, but in some people it happens so much that the air going through the narrow throat becomes turbulent and produces vibrations in tissues at the back of the throat, and that's what the noise of snoring is. In some people it collapses down so much that not enough air can get through, that's a hypopnea, and in some people it collapses down completely and blocks off, and that's an apnea. So why do some people get it and some people don't? If the throat is more narrow to start off with, then it's much more dependent on the throat muscles working, and so therefore during sleep when the throat muscles are relaxed, then the collapse can become critical. So probably the commonest cause of a narrow throat is obesity. So when we're obese, not only is it the fat on the outside that we all recognize and see, but also there are increased fat deposits internally, and that includes in the lateral pharyngeal walls. So people who are obese have more narrow upper airways. Also, some people are just genetically predisposed to having narrow throats. So here we have Chesty Bond with his big, strong jutting jaw and a big wide throat. And if you notice in all of the heroes like Batman and Superman, they're sort of drawn like this. So these people don't snore when they go to sleep. Whereas this poor fellow has got a small jaw that's set back, so he's going to have a small upper airway and very prone to snoring and getting sleep apnea if he doesn't already have it. So some people just have a genetic predisposition to having a small throat. There's also a difference between men and women, and that's because the pharynx is different between men and women. So that men are twice as likely to have snoring and sleep apnea than women, even allowing for obesity and being overweight. Then the other thing is alcohol. So that having alcohol on board when we go to sleep makes our muscles relax more, so that the throat muscles were more likely to be relaxed, allowing the throat to collapse more. So that's real, that people snore more after alcohol and more likely to have sleep apnea. And as we get older, then the throat muscles also tend to relax more during sleep, so that sleep apnea becomes more common in middle-aged and older patients. So this is what happens when we go to sleep. In someone who is developing sleep apnea, their throat muscles relax so that the throat collapses down and blocks off. Air can't get through, so this is an apnea. But they're still trying to breathe. So they're generating a negative pressure as they try to breathe in, but no air isn't getting down into the lungs. So the CO2 starts to rise, oxygen levels start to fall. There are negative pressure receptors in the upper airway. There are stretch receptors in the lungs and the chest wall, all of which send messages to the respiratory centers in the brain stem to increase respiratory drive. So on the next breath, they try even harder to breathe, generating a more negative pressure, but the throat's still collapsed. And this keeps occurring until a certain threshold of respiratory effort is reached, which then causes the brain to wake up or arouse from sleep. The throat muscles then work again, open up the airway, take some normal breaths, breathing occurs, the person goes back to sleep, and then the whole cycle repeats itself. So the characteristic feature of obstructive sleep apnea is that the person is trying to breathe during the apneas, but also that it's repetitive. So it's breathing, not breathing, breathing, not breathing. So when this occurs, it disrupts the sleep. So then the person can be sleepy during the day. Bed partners recognise the snoring, the apneas, the disrupted sleep, and the sleepiness during the day. Because it's a chronic condition, sometimes patients themselves don't recognise they're getting sleepy. They feel as if they're just getting older or they work hard or whatever. But often people around them will see just how sleepy they are. Patients themselves will recognise the sleepiness sometimes. Generally, they're not aware of these apneas because they're so brief they don't wake up for long enough to be aware of them. But occasionally they will notice a choking sensation as they're falling asleep, and literally the throat is collapsing down and choking them. They wake up feeling unrefreshed with headaches, poor concentration, memory, intellectual impairment, personality changes, all the things that go with chronic sleep deprivation. They're prone to getting accidents, particularly car accidents. Men will complain of impotence. Nocturia is also recognised as a symptom of sleep apnea, and rarely collapse. So this is when someone is so sleep deprived that when sitting down, they'll just fall asleep and fall off the chair. So obviously it gets misinterpreted as a collapse, a faint, an arrhythmia, something like that, but occasionally it's just someone being so sleepy that they fall asleep and fall off a chair. It's worthwhile looking at the alcohol consumption and medications that can predispose to sleep apnea. Nasal symptoms. So when we go to sleep, we preferentially try to breathe through our noses. So if our noses tend to be blocked up, then we're generating more negative pressure in the upper airway, more likely to have collapse. If there's a history of upper airway surgery, it's worth noting. What type of work they do is important, because if their work is very dependent on them being alert and attentive, such as school bus drivers, then they need to be fast-tracked through the system to get the sleep apnea diagnosed and treated. They also need to be aware of the implications of diagnosing sleep apnea, so that if it is diagnosed, then they'll need to report to work authorities or driving authorities, license authorities, things like that, depending on what situation they're in. And understanding a family history is important. It is very common these days for people to know someone else who has sleep apnea or CPAP, and understanding their biases or predispositions towards sleep apnea is important when dealing with them. The reason we get concerned about all of this is because of the daytime sleepiness, impaired cognitive function, road trauma. Also, sleep apnea is a risk factor for hypertension. And if people get significant oxygen desaturation with the sleep apnea, it does increase their risk of strokes and heart attacks. So these are the reasons that we try and diagnose and treat sleep apnea. There is a way of documenting how sleepy someone is, and this is the Epworth Sleepiness Scale, invented by Murray Johns at the Epworth Hospital in Melbourne. So it's an 8-point scale. The person indicates what chance they have of falling asleep in these different situations. So they get a score between 0 and 24. If normal is 0 to 10, if the score is more than 15, they're twice as likely to have a car crash. And this is now incorporated into assessing people's ability to drive. So it's something that gets used by clinicians. We know that sleep apnea has an effect on cognitive function because of this disruption to sleep. So people have reduced reaction times. They don't perform well in tasks that require sustained attention and vigilance, reduced tracking, reduced visual and verbal memory, reduced visuospatial and construction abilities, and also depression is known to be associated with sleep apnea. Driving is a particular issue, and road traffic authorities around the country recognise that sleep apnea is a condition that affects driving. So people who have sleep apnea that's not treated need to report their sleep apnea to the traffic authorities because falling asleep at the wheel can be dangerous. So it does vary a little bit from state to state. In Victoria, if people go onto CPAP and have their sleep apnea treated adequately, then it's not an issue. Unless they're commercial truck drivers, they should report to VicRoads. And VicRoads are generally happy for people to drive if they're using CPAP. But if they're not going to be using CPAP, then our responsibility as healthcare professionals is to let the patient know that they have to report their condition to VicRoads. And then it's the driver's responsibility to do that. We would do it if there was a public interest. So, for example, obviously a school bus driver who's refusing treatment, then that would be reported to VicRoads. But VicRoads would cancel a person's license and go and tell them to get the problem sorted out. This is what we do in a sleep study to try and identify sleep apnea. This is from the Compumedics system, which was invented in Australia, in Melbourne, in fact. And on the top 5 lines here, this is running over 30 seconds. And that's just a standard ECG. This is a surface EMG on the face. These two are eye movements, and that's the EEG. So we look at these 4 black lines to work out whether someone's asleep, what type of sleep they're having, and if they're having arousals from sleep. So this is looked at 30 seconds a page right throughout the whole night. Then we look at the bottom part. So this is over 5 minutes. This is oxygen saturation from 50 to 100%. So you can see with someone with bad sleep apnea, they have these repetitive desaturations through the night. This is airflow, which these days we measure with a nasal catheter. So you can see they're breathing, they're not breathing, breathing, not breathing. We have bands around the chest and the abdomen. And what we can see here is that when they're not breathing, they're still trying to breathe, they're making efforts. So that tells us it's obstructive sleep apnea rather than central sleep apnea. Here you can see sound, so the snoring. And then here are recording of leg movements, so that the person is kicking their leg every time they have one of these arousals from sleep because of the sleep apnea. So that's what we record in a sleep laboratory when they have a sleep study. So the management of sleep apnea, if the patient is obese, then often they can fix their sleep apnea just by losing weight. However, of course, losing weight is not easy and doesn't happen very quickly. So while they are losing weight, we need to go on to these other treatments, which we'll go through. So CPAP sounds horrendous, but it's not like that at all. This is what a modern CPAP mask and equipment looks like. And that tubing goes down to a small pump, which is very quiet. If you're watching this webinar on a computer at the moment, the CPAP pumps make the same sort of noise that your computer will be at the moment. Certainly much less noisy than the snoring. So CPAP was invented in Australia by Colin Sullivan in Sydney, first published in 1981. And basically it's just a pump that blows air through that tubing into a mask. The air pressure goes into the back of the throat and just holds the throat open. It's very effective. It gets rid of all of the sleep apnea and as well as the snoring. But it's not a cure. The person needs to use it every time they go to sleep. Most people tolerate it fairly well, but some can't. They just can't get used to it. Its major side effect is the vasomotor rhinitis. So the cold, dry air blowing on the nose irritates the nose. This is best fixed with heated humidification, which most machines have these days. The machines cost between $1,000 and $2,000. Private health insurance sometimes cover it. You can get automatic CPAP machines these days, which are more comfortable to use. But remember that a CPAP machine is not a ventilator. It's not helping the person breathe. It's just holding open the throat so that they can breathe themselves. And when someone does go onto CPAP, then here they are, their breathing is completely back to normal. So it's very effective. It's just whether the patient can tolerate using it, and for some people whether they can afford it or not. The vasorhinitis I've explained. The pump being noisy is not really an issue. It's certainly quieter than snoring. Sometimes air leaking around the mask can be noisy. They should go along to their supplier and get the mask fitted, get it fitted properly. As well as going to the supplier, some places have their own CPAP clinics like we do at the Austin to help people with these sort of problems. Upper airway surgery is not done very much in adults because it's a difficult operation, it's quite painful and not that successful. It's much more likely to be done in school-aged children by removing tonsils, and adenoids can often cure them. So in young adults, I would get them to be seen by an ear, nose and throat surgeon for an opinion, but surgery in adults is generally not that effective. Mandibular advancement splints are like a mouth guard that fits on both the upper teeth and the lower teeth. It needs to be fitted by a dentist. It's designed in such a way to pull the lower jaw forward to create more room in the throat. So it's not preventing the collapse, it's just creating more room. There's a limit to how much the jaw can be pulled forward without it becoming uncomfortable, so it doesn't always work. It tends to be used more with people with milder sleep apnea or just snoring that they want something to fix. Sometimes people only have sleep apnea on their back and not on their side, so people move around when they're asleep without realizing it. So a simple thing like having a tennis ball in the back of the pajamas is often enough to keep people off their back when they're asleep. So for the small number of patients that have sleep apnea only on their back and not on their side, this can be a cheap, effective treatment for them. And we routinely monitor what position people are sleeping in when we do sleep studies. So I'll just quickly finish off by talking about periodic limb movements. So this is closely linked with restless leg syndrome. Restless legs is what patients complain about. So when they're going to sleep, it's an uncomfortable, irritable type feeling. They can't quite describe it. They feel as if they have to get up and walk around to relieve it. So it's not a pain, it's not numbness, it's not tingling, it's just an uncomfortable feeling. Periodic limb movements describes what we detect on a sleep study. So restless legs tend to occur at rest, usually in the evening, usually in the legs, but sometimes the arms can be involved as well. Periodic leg movements are a regular kicking of the legs that occur usually in stages 1 and 2 sleep. They can be associated with an arousal, and if the arousals are frequent enough, it may lead to excessive daytime sleepiness. But often we'll see leg movements on a sleep study, particularly in older people, and they have absolutely no complaints about it, no symptoms whatsoever. So in those sort of situations, we wouldn't bother about it. doing anything about it. It's really only if it's causing a problem for the patient. Pretty much everybody who complains about restless legs will have leg movements on a sleep study, but many people with leg movements on a sleep study won't have any symptoms at all. It tends to be more common in the elderly, sometimes runs in families. It's usually idiopathic, but is occasionally associated with iron deficiency, so we would always look for that by checking their ferritin, and also with renal impairment. It is associated with antidepressants, particularly tricyclics and SSRIs. So that's a recognized side effect of those medications. And this is what it looks like, just a periodic kicking of the legs during sleep, and this is during stage 2 sleep. The breathing and everything else is normal, it's just that the legs are periodically kicking throughout sleep. The management is occasionally, when you do find an underlying cause, is to treat that. And also if they're on drugs, to see if they really need to have the antidepressants. If it's idiopathic, then there's no easy treatment for it. Dopaminergic agents can help. So levodopa can be used, but there is a loss of an effect over time with regular use and augmentation of symptoms. So augmentation means that the symptoms get worse despite ongoing treatment of the drug. So really, any of these drugs, patients should not use them continuously long-term. They should use them intermittently, or just use them for a few weeks, then stop for a few weeks, and then use them again for a few weeks. They also should wean off them carefully if they are going to stop them after they've been using it for a while, because they can get rebound symptoms as well. ROPINIROLE and pramipexole tend to be used as dopamine agonists. We start with a very low dose because they often have side effects of nausea, postural hypertension, sleep attacks, visual hallucinations, and even with these newer drugs, augmentation can occur. So the treatments are not magical. You really need to make sure that the symptoms are quite bad to justify the potential for these side effects. The older ones like cabergoline and pergolide we don't use anymore because of concerns about fibrosis and also tricuspid and mitral valve fibrosis and incompetence. So we don't use those anymore for leg movements. Clonazepam doesn't control the leg movements, but it just makes people sleep a bit better, so it's not that effective. Opiates can control the leg movements, but there is a concern with side effects, constipation, and developing addiction. Some people have tried carbamazepine with varying success. There's no strong evidence to treat those. So that's common sleep disorders in a nutshell. Insomnia is very common. Obstructive sleep apnea is very common. Periodic leg movements are less common and difficult to manage. But I'll hand it over to Genevieve now to see if anyone's got any questions for us.
Thanks very much, Christopher, for, it's such an interesting topic, and as some people say, really, the community's sleep is really becoming quite a public health issue. We've got a couple of questions that have come through, and I've got a couple myself that I'd like to address to you. Someone has just raised the issue about their own personal sleep patterns and the fact that, is it really a matter of 9 hours, 7 hours, 8 hours? From what you've said, it really just depends on the individual and the impact on their sort of daily functioning, really, as to what is best for each individual. Is that correct?
That's correct. So the average is about 7 to 8 hours a night. Some people will need a bit more than that. Some people will need a bit less. The way to see if you are getting enough sleep is to really that you're functioning well during the day without getting sleepy and falling asleep in quiet situations like listening to webinars. That's really the determinant of whether you're getting enough sleep at night, whether you're sleepy during the day.
Mm-hmm. And someone's also posed the question just with regards to your your comment about drugs not being a sort of a common treatment mechanism, but it was raised with regards to the use of drugs, in particularly in shift work related insomnia. Is there a role for the use of drugs in the treatment in that instance?
In the long term, not really. People who have shift work, they really should avoid at all possible having rotating shifts, because that completely disrupts the circadian rhythm, and they're really going to have problems sleeping, and there's no really easy way of treating that. If it's a regular night shift, or evening shift, they should try and maintain those regular sleep times even when they're not working, because once the circadian rhythm gets into a set pattern, it's best to keep it like that. If they need to change their circadian rhythm to fit in with the shift, then the use of melatonin and bright light therapy are quite useful. But it does take a few weeks to shift the circadian rhythm around. So it's not the sort of thing you can use, I'm going to do night shift during the week and then operate during the, be awake during the day at the weekend and then go back to nights during the week. You can't shift the circadian rhythm that quickly. Trying to use sedatives to get people to sleep is not really a good thing. Many of them will have a hangover effect, so when they're trying to be awake to work, then they'll still be feeling drowsy from the effects of the drugs. They'll get addicted to them quickly, tolerance develops quickly. So it's really dealing with the underlying behavioural issues rather than using drugs to sleep these type of sleep problems of insomnia and circadian rhythm disturbances.
We have another question. You made the mention of the fact that question, why is nocturia associated with sleep apnea? When
we go to sleep, we make less urine than we do when we're awake. So if a person with sleep apnea has very disrupted sleep, they'll be making daytime amounts of urine, so their bladder will fill up quickly. Also, when they have these little arousals from sleep, they'll be more aware that their bladder is full, so more likely to want to get up and go to the toilet. So that's why nocturia is a symptom of sleep apnea.
And just one question in the event that there's no other questions coming in. Just you've made the comment earlier about people's perception of their sleep can often be inaccurate. Is it really for health practitioners working with people for whom sleep may be an issue, is it really just a matter of the health practitioner determining the impact of possible lack of sleep, given that the people's perceptions and recollections of their sleep may be inaccurate?
Yeah, that's exactly correct. So that if the patient is functioning during the day, they're not falling asleep at the computer, not falling asleep in front of the TV at night, but they're complaining about not being able to sleep at night, they're just worried about their sleep. The main issue there is to encourage the person not to worry about their sleep. Don't think about the sleep. Have some set times to go to bed. Go to bed at that particular time, get up in the morning the next morning, and just let the sleep do its own thing during the night. Don't worry about it. Don't think about it. Don't be concerned about whether you've got enough, whether it's the right type of sleep. So it's really a matter of dissociating the person's thought processes from the sleep and just being relaxed and passive about the sleep, and it will come to them. So if a person says, look, I go to bed at night, I just lie awake for 2 hours, don't worry about it. They probably haven't been awake for 2 hours. They probably don't know how long they've been awake. If they are looking at the clock, well then throw the clock away. Don't look at the clock. Just go to bed, relax, dream about some lovely tropical island or whatever turns you on, and get up in the morning and just do your daily thing.
Okay, Christopher, we're just before 8 p.m. and with no other questions forthcoming, once again I'll thank you for a most interesting presentation this evening on a very important issue. I'm sure all the participants tonight will also take a few personal tips away from what you've told us. So look, thanks again very much, Christopher. Could I remind all the participants for tonight's webinar to please take a moment to complete the exit survey, and thank you once again for joining our webinar tonight, and good night.
Thanks very much. It's been a pleasure.
Great. Thanks, Christopher.